Welcome, everyone, to this panel discussion on automated chest compression technology. Joining me today for this panel are a number of experts in resuscitation as well as end users in resuscitation technology. I'm going to start by introducing everyone on our panel, starting with you, Katie. Could you tell us a little bit about yourself and your background in EMS?
Absolutely. Hi, everybody. My name is Katie Hall. I am in East Tennessee, currently the stroke coordinator here at UT Medical Center. My background is EMS. I've been a little over 11 years now, and just recently obtained my critical care paramedic certification. And I've been teaching at the EMT basic and advanced EMT level at Rome State Community College now for a couple years.
Great to have you here, Katie. Dr. Holley.
Hi, everybody. I'm Joe Holley. I am the EMS Medical Director for the state of Tennessee and the city of Memphis and several other community 911 responder services. A longtime researcher in the cardiac arrest resuscitation space and a barbecue aficionado.
Very good. And we'll kind of contrast that with Dr. David Wampler's experience in barbecue.
Hi, I'm Dave Wampler. I'm an associate professor of emergency health sciences at UT Health Science Center in San Antonio. Currently serve as a director of clinical research for the Office of Medical Director for San Antonio Fire Department. Made a few papers in the area of resuscitation. Specifically, I've done a couple of papers looking at automated chest compression devices. And Texas will crush anybody else in barbecue.
What say you, Tom Bouthillet?
Thanks, everybody. My name's Tom Bouthillet, EMS Battalion Chief with Hilton at Island Fire Rescue, lifelong student and resuscitation enthusiast, and I have had barbecue in Texas, and it was not horrible.
We'll leave it at that. Mel, I know West Michigan isn't noted for barbecue, but we'll kind of leave that one alone for now. But if you could just introduce yourself to the group.
Thanks, Mick. My name is Mel Oakley. I'm a critical care paramedic in West Michigan here, also an agency director for a small rural agency, and also run a training and consulting firm putting on initial education all over the state.
Excellent. Well, I'm glad everyone's here to participate in the panel, and we're going to try to extract some insights for EMS leaders about what you should be looking for when considering automated chest compression technology to complement the presentation that Dr. Wampler did on this. I'm going to start with you, Katie. You work in more of a rural environment with your EMS career. I know you're now working in the Knoxville metro area, but you're still working with a more rural EMS provider agency. And could you comment, first of all, on whether or not you're using automated chest compression technology?
Yes, and that is actually a piece of equipment that we've utilized for a few years now. They made the decision to implement that on each of our trucks, and it's acted as a third man to provide chest compressions. Being in a rural setting, sometimes it may take us 30 minutes to get to our patient, depending on where they are in the county. And so we have a lot of volunteer services in the area. So by the time we arrive and they've utilized all of their personnel in providing CPR in that time frame, it's nice to have a team member rather to kind of implement the perfect compression every time.
Indeed, indeed. Dr. Holley, do your agencies all use automated chest compression technology?
I don't know that I can say all, but a vast majority do, and we have a long-standing relationship with mechanical CPR devices.
Okay. And how about in the San Antonio area, Dr. Wampler? Is that pretty ubiquitous out there, and maybe even through the rest of Texas?
Yeah, so San Antonio Fire uses automated chest compression devices. Sort of an interesting story. When we deployed it, we have almost 50 ambulances. We only were able to procure 10 of them. So we set up a really nice experiment in a natural experiment in figuring out if this thing actually works. And so, yeah, we've been using it now for, long story short, right? we've been using it now for about 7 years with considerable success.
Excellent. And how about in Central or West Michigan, Mel? Are you using it with your more rural agencies? And if you could comment on its utilization amongst your neighbor colleagues.
Yeah, for sure, Mick. We've got one on our frontline ambulance, and many of our colleagues do as well. It's been a godsend in the fact that we have, like Katie mentioned, very long response times, which means very tired first responders by the time we get on scene, and having the addition of firefighter. I guess I can't say the name, but the one who doesn't get tired, and that's pretty handy to have. A lot of our collateral agencies have put them in place as well and had similar success. Being able to take a person with compressions down the road has been really a big game changer for us, because that was a non-starter for us kind of here recently. So it's good stuff.
Okay, and Tom, how about on Hilton Head Island?
So we did implement automatic chest compressions in our system, and our survival rate went down significantly. So we no longer use mechanical CPR as our primary resuscitation strategy, but we still occasionally use it during special situations. So I do believe there are valid uses for mechanical chest compressions, but we think that the specifics of what's happening should determine whether or not it's utilized.
And that's a great segue into my next question, and I'll have you try to continue on, Tom. I want to know why you use it when you do use it, and at what point in your resuscitation workflow do you introduce the device into the code?
Sure. So typically, we will use it more often for non-shockable cardiac arrest than we do for shockable cardiac arrest. And we usually will transition to it after the 20-minute mark, sometimes after the 40-minute mark. So it all just kind of depends. For one of our survivors from 2017, we had gotten a return of spontaneous circulation on scene. We obtained a 12-lead ECG that was showing LAD occlusion. The patient re-arrested. We got ROSC a second time, applied the Lucas device as a precaution, loaded the patient for transport. He coded again immediately after being loaded in the back of the ambulance, and we were able to just push a button. It started compressions. We transported him in. He went to the cath lab. The coronary arteries were non-navigable, so he was transitioned to an Impella, transferred to a tertiary care center, and then, I'm leaving out a lot of details, but he ended up being discharged from there neuro intact. So long way to get there and to survive, but sometimes it's not pretty, but these folks are really sick. And so if we're in it for the long haul, I definitely acknowledge there are times that it can be an important life-saving tool.
So in that, not necessarily that particular case, but in general, when you choose to introduce the automated device, at what point in the code do you typically introduce it?
Well, I mean, at first, when we realized that that we had an issue, we noticed that our survival rate had dropped kind of precipitously, which surprised us, number one, but also alarmed us, because we had really trained on applying the device in a training environment on a mannequin. We knew we could do it in less than 10 seconds. But when we started looking at code stat data, it turned out that the application time on real patients wasn't always so straightforward, and there could be up to 3 pauses when applying mechanical CPR. And we also felt that it was disrupting defibrillations on either side of the peri-application period. And so those were the things that kind of led us to those concerns initially. But I would say it's up to the discretion of the team that's on scene, using crew resource management and leveraging team experience, whether or not they make that decision. And then we'll usually discuss it after to just kind of find out what they were thinking that led to that decision. Not in a critical way, but just so that we can all sort of understand and learn. And I would say most often we apply it during ROSC in case the patient re-arrests. And then there are other times if it's a youngish patient with a good story, witness collapse, bystander CPR, and we're say at the 40-minute mark and we still have a good end-tidal CO2, we will transition them to mechanical CPR and then just bring them into the hospital at that point. We don't really like to stay on scene past the 40-minute mark. I don't know that that's evidence-based, but in the era of high-performance CPR, we could be there for hours and still have a good end-tidal CO2, and there has to be an endpoint, and we're not going to terminate that code in the field for a young patient that had bystander CPR and an initial shockable rhythm. So we don't want CPR quality to be poor during transport, and we want to get it all the way across the finish line to the hospital with integrity. And it's also safer for our staff in the back of the ambulance. So for all those reasons, we might consider transitioning to mechanical.
Okay, excellent. And Mel, you're in a little bit different situation, as you told us about earlier, where both you and Katie are coming in on arrest scenarios typically where CPR has been ongoing for a period of time by the first responders before your more rural ambulances arrive. And so my question for you is, I know that you're using mechanical CPR, but do you really view it as more of a force multiplier or something to ensure better quality and consistency in the CPR that's delivered?
I'd say both. We have responders that are very tired at that point, so the consistency of CPR is going down quite a bit. We have an EMT and a paramedic on our ambulance generally, and that's they're both going to be pretty task saturated upon arrival. So having them take over compressions for our more wore out first due responders is maybe not the best use of their resources. So we sort of a force multiplier, but also to ensure that consistency. And like Tom was just describing, those patients who are really good candidates for going down the road, we can't do continuous good CPR going down the road at all, and certainly can't do it safely. So we try to identify pretty early on those people who are going to be good candidates for really awesome outcomes and get them going pretty quick. As I've described in other sessions here, we drive for about an hour to go to anything with an interventional capacity. So getting going soon, identifying those patients with good candidacy and moving quickly, that's where we really kind of use it as a force multiplier. Is we're able to apply that and get moving when it makes sense.
And Katie, how about your experience in Tennessee? Is it similar to Mel's, or do you have different reasons for applying the device, maybe at different time intervals?
I would say that it is actually probably very similar to Mel, but in the sense of, in my area, a lot of the providers are very familiar with it, and is something we introduced that equipment and the concept of that equipment kind of in the initial education scene, so that they're comfortable with placing that on prior to clinicals, because that's such a popular piece of equipment in the area that they could encounter that with our different clinical sites. There was recent situation that I had learned about while out in the region doing some education of an instance where a family member had drove their sick family member to an ambulance station because they knew it was there, knew they were available, and they implemented CPR, and they knew that they didn't have that particular piece of equipment, but I think the fire department did. And so they were able to make those connections. They regained ROS, and this patient actually continued to rearrest. It was most certainly a cardiac patient with 100% blockage, and went through place stents, full neurologically intact discharge, and that family returned to provide that particular unit with a automatic chest compression device that they had purchased as a gift to them. So kind of knowing your resources, knowing when it's best to utilize those resources. And Tom made the great point of it's very nice to have that already in place during transport so that you can push a button versus trying to accommodate doing chest compressions while going down the road and transporting a patient. So it's definitely a great tool and pretty well utilized in our area.
Dr. Holley, in the metro area of Memphis, you've got a little bit different scenario from Mel and Katie in that you're getting on the scene a whole lot sooner in the whole scenario, uh, unless it was a patient that arrested in front of EMS. But in that context, do you introduce mechanical CPR pretty early into the resuscitation, or do you wait a little bit longer into it? And overall, what's your rationale for using it? Is it again a more of a force multiplier rationale, or is it for quality and consistency of CPR?
So in general, in our area, we tend to implement early, and usually it is fairly standard manual CPR until the device is brought in, set up, and ready to go. Our primary reason for implementation is around consistency. And that's I think some of that has to do with the challenges of a very large fire department with a lot of variability in skill level. And so this device allows us a substantial increase in the consistency of compressions that we can deliver. But we certainly have had our struggles with issues like time of a pause during placement and that sort of stuff. That's gotten much better. It's taken quite a while and sort of continuous quality improvement and training around those issues to really make a difference there.
And related to that, how would you have assessed the quality of your manual CPR before you introduced this technology to your department? So, was your assessment of their general chest compression quality, rate, recoil, all of those different parameters, pretty good, or was it not so good? And then the CPR technology was brought in to try to make that better?
The answer is yes and yes, in that we had some teams that were really superb and others that were not. And I think, for us, despite persistent, focused efforts to improve the quality across the board, we continue to have wide variability. And this was an option that provided this consistency and removed a lot of that variability that we had out there. So that the consistency of compressions, et cetera, were much improved.
Okay. And how about in the San Antonio area, Dr. Wampler? What was your experience, both in terms of the compression quality before automated CPR was introduced, and to try to characterize its utility, more as a force multiplier or there for consistency?
So we sort of optimize our use of automated chest compression for times of transition. So the devices are on our ambulances. And so typically our first responders will get there first. And our first responders have a crew of 4. They will do high quality chest compressions. And we actually use AC/DC chest compression. So the active compression, decompression technology as well. We do that on the floor for about 10 minutes. We don't really switch over to the automated chest compression until we're ready to move our patient either from the floor to the stretcher or from the stretcher to the unit. So somehow during transition, when we're going to be stopping CPR to do other things anyways, because you can't do CPR when you're lifting the patient onto the stretcher. No human can do that. Well, automated chest compression device can to some degree. So that's when we start to try to integrate the automated chest compression devices. We typically go about 10 minutes on the floor before we even start thinking about moving the patient, with some exceptions. And those exceptions are the shock go kind of a situation. Then if we are actually going to be transporting a patient without a pulse, they have to be on some sort of a device because we can't safely and effectively do CPR during transport.
Okay, fair enough. And did you observe any difference in your survival rates? I'll ask you first, Dr. Wampler, and then you, Joe. Before and after the introduction of the technology.
So no, we did not see any kind of improvement in survival. Really, these devices do really good CPR, but so do EMS responders. So we don't really see it as a life-saving device. We see it as a device that will help our medics do really good resuscitation. On the flip side, what we also noticed once we started our automated chest compression device, the energy level of the room goes down, and we get a little bit of this cognitive offloading of all of the things that have to be done, including high quality chest compressions. And so we tended to do other things, like we gave more epinephrine and we did more airway stuff. And so I think one of the reasons why we didn't really see a huge improvement is because we might have changed some other things unknowingly.
Okay, fair enough. And how about your experience, Dr. Holley? Did you see a change or delta in your resuscitation survival rates with this?
We did. It did go up. I think, from my perspective, that was due to the improvement in consistency. But I think Dr. Wampler made a really powerful point, and that is the effect of these devices on sort of the level of chaos in the room is profound, and really calms everybody down, and I think allows folks to really focus on the myriad of other details that are so important in cardiac arrest. This is a bit of cognitive and work offloading, and you can then focus your attention elsewhere. And I think there's great value in that as well.
Something I'm curious about also is, again, thinking about this EMS decision maker that's considering the purchase of this technology, assuming that they don't already have it in place. Have any of you experienced pushback from your crews with the introduction of this technology? And Mel, I'll let you comment on that one first.
No, as a matter of fact, my crews were thrilled to have this brought on board. Like I said, they're pretty wore out from working these things kind of all by themselves, if you will. Our fire departments were thrilled to have us bring this to play and bring this resource to bear. And our crews were kind of relieved. Like Dave said, there's a lot going on, and the cognitive offloading capability of this device. I hadn't thought of it in that fashion before. I think he put it in the best frame possible, but they were thrilled to have that. I think that would be the best way to say it.
Okay. And Katie, what was your experience?
I think that overall it was received very well. And it's a challenge, not necessarily challenge, but another way that, we have to kind of communicate with bystanders and family members. It looks a little medieval in a way because, those are machines. It's not us actively doing that. So it kind of we've noticed that you kind of have to take the moment to say, this is kind of helping and kind of explaining exactly what it is, because we show up and we're doing many things at one point in time very simultaneously to their family members. So sometimes it takes a minute to kind of let them understand exactly what's going on in that sense. I would say that our firefighters and our first responders definitely received it very well. They were very excited to have the help join us. And it's kind of been a little bit of a game changer. And I would say that, David's comment on the workflow and kind of just lowering the chaos in the room to really step back. It's almost like you can take a nice deep breath and just kind of see what's in front of you and formulate more of a game plan in that resuscitation effort.
Certainly. Tom, what was your experience on Hilton Head Island when, there's always the resistance to change that people talk about, but in the case of introducing automated CPR, I know you ultimately didn't take it as a primary intervention, but did you have any cultural issues, resistance to introducing the technology?
No, I mean, firemen are funny, right? They'll dig a trench from here to China. If you ask them to, they just want to know why they're being asked to do it, and they want to be properly trained. And I think on Hilton Head, we're just fortunate because we're not a rural area with 30-minute response times, but we're not a city with over 1,000 staff to train either. I've got like 45 paramedics and 55 EMTs. I know each individual person by name, and we can train to that level. So it's just a different situation. So by that time we had buy-in, and they weren't worried about what they were being asked to do. They just wanted to make sure they were doing it properly. So there was no pushback or problem. The only thing that I would say, like in 2021, I've noticed sometimes trying to have a conversation about high performance CPR and systems that already use mechanical CPR, they don't think they need it because they already do mechanical. And there's bariatric patients, and there's people for whom, mechanical CPR, they're just not a candidate. So it doesn't take the problem of manual CPR and make it magically, like, poof, go away. You still have to be good at manual CPR. And I would say, with all the different options in 2021, whether it's minimally interrupted cardiac resuscitation or high performance CPR, mechanical CPR, I think we are in an era now where everyone should bring their receipts to the conversation and present their CARES data and their outcomes data, so that we can all learn what really works, so that we can all pick the most optimal strategy for our system based on our unique circumstances, but in an evidence-based way.
Sure. Now, Dr. Holley, you're in a more urban environment. I don't know if your workforce is unionized or not, but in my experience, different parts of the country, sometimes these factor into the acceptance of new responsibilities, new tools, et cetera. Have you had any issues with acceptance of the technology by your workforce?
No, we are not a union, heavily union shop anyway. And we have been utilizing mechanical CPR devices for well over 10 years. We have over 100 in the field. So lots and lots of experience. Apart from the initial, what is this thing, and what are my responsibilities, and I have to do some more training. I think overall the acceptance has been quite good, and the devices are utilized quite commonly now with no pushback at all. So just a bit of growing pains with it initially.
Okay, and how about in San Antonio, Dr. Wampler?
So San Antonio is a heavy union shop, but you know what? The union is interested in protecting their guys, and this thing helps the guys. It helps them do their job well. It makes it easier on them. Yeah, it's heavy. You got to drag it into the scene, but once you've got it there at the patient's side, it's doing good medicine. It's doing high quality chest compressions, and our medics aren't killing themselves trying to maintain that level of efficiency.
Well, let me flip the question before I let you back off the hook, Dave.
Okay.
How about the receiving hospitals? What was their reaction when you introduced mechanical CPR and they see this starting to come through the door on selected cases? What was their reaction? Was it like masked pants of years gone by, where the first thing they wanted to do was cut them off, or how did they react?
So the way that we got our first 10 automated chest compression devices it was from a grant from one of our hospital systems. And then our medics bring the patients in with chest compressions going on without somebody having to get up on a stool. Our hospitals are like, leave them on there. How long can y'all stick around while we finish this resuscitation?
Did the hospitals get their own machine once they saw EMS using them?
Several hospitals do have them, and some hospitals will say, "Hey, we've got a code here. Can you go out and get your device and bring it in here for us to use?"
Katie, when you first started bringing patients in with the mechanical CPR device in place, what was the reaction of the emergency departments? Positive, negative, skeptical?
I think initially, like the 3 to 5 orderlies that usually line the hallway waiting for us to go were kind of excited about that implementation. But it wasn't long that they purchased their own, and it's actually the same that we use, because there's one hospital in my area where I've spent most of my career, and so we found that by having that same type of equipment, we are able to switch out batteries with there, so that when we go back in service after restock, that equipment is fully charged for the next code in that sense. And so everybody's really kind of became, been on the same team. And it's oftentimes left in place if we come in and we have that utilized, and we're able to retrieve that equipment afterwards. And so it's definitely something that everybody kind of got on board, and the timing was pretty close together.
Okay. And how about your experience, Mel? How did your hospitals react?
We were actually regionally pretty late to the party. So my colleagues had been bringing patients in arrest to our facilities, all three directions we can drive. They'd all been receiving patients with mechanical CPR for, honestly, years before we started doing it. So it was sort of like, hey, cool, welcome to the party, gang. So yeah, we didn't really have any hurdles there to overcome at all.
And did your hospitals also purchase the technology or not?
Some of the regional facilities have. Our local hospital doesn't have that, but we do. So if they need it or want it, they generally will ask us to come and use it.
And Tom, if you could comment on the reaction of your receiving hospitals as well, because it seems like there's, been, I think it's a positive thing in some regards that EMS was perhaps much earlier to the game with using waveform capnography than our emergency department colleagues. And there's a couple other scenarios like that as well. And it seems like automated CPR is kind of fitting into that category as well. So if you could comment on, what their acceptance of it was.
I think at first they weren't expecting it, and we probably should have done a better job, bringing it over and showing it to them and doing some education before we just kind of surprise show up with mechanical CPR. But once they understood what it was, they actually purchased one for the emergency department, and I think they purchased another one for the cardiac cath lab. And from what I hear, they actually like it inside the hospital, particularly when I've asked that question, because unlike fire rescue, where we know who we're going to be working with every shift and everyone's trained the exact same way, the kind of constellation of people that work in a nursing unit changes daily. And the bed is so big that you might have kind of a smaller person standing on a stool trying to do compressions in the middle of the bed, and it's just not very effective. So I think for consistency reasons, and once it's applied, we know that it can deliver excellent chest compressions, that, for those reasons, it might make a lot of sense inside the hospital. So they seem to prefer it.
Okay, so great. So we've got that perspective, and just kind of wrap this up very briefly, if I could get you to comment on what other feature or functionality might you like to see in this technology that perhaps isn't there now. So feel free to kind of put on your imagination hat and dream a little bit about what you would like these devices potentially be able to do that perhaps they don't do right now. And I'll start with you, Mel.
It's a great question, Mick. I actually don't have an answer for this one. I know I'm usually the dreamer in the group, but I don't have a great answer for you. I'm sorry.
Well, that's might be affirming for the manufacturers that perhaps they've got their bases covered fairly well. How about you, Tom? If you had the magic wand, what would you like these devices to be able to do that they perhaps don't do now, or maybe enhance a certain feature or functionality?
I'd like for artificial intelligence inside the automatic chest compression machine to understand the end tidal CO2 and other parameters that are happening with the monitor, so that it could help predict, for example, if it was a piston-driven device that was walking off the sweet spot on the chest and getting off center, and it would notice a drop in end tidal CO2 and alert, so that someone could put eyes on it to verify that they had good pulses with it and things like that. So I guess I would like to see the devices get smarter and leverage other parameters that are being measured during the resuscitation.
Sure. Okay. Any thoughts along those lines, Katie?
I think that's a fantastic point. And I was actually kind of thinking along the lines of, our patients are certainly not cookie cutter people, and maybe to kind of better utilize those for various shapes and sizes might be something that's more beneficial, because we know when we're talking anatomical differences between patient to patient, the process of CPR, there's tend to be more effort required And that certainly tires out. And when you're tired, you're not as effective. So being able to utilize that equipment on, various size individuals would certainly be great. And maybe like some kind of additional internal battery where, if the battery is detached, something that's going to just lengthen the time frame that you can utilize that. Because if you're having, a long transport time, if you're thinking in a rural setting, if you're able to regain ROSC and make that transport with that cardiac patient whose end goal is a cath lab, because, if we don't fix the problem, we're not getting anywhere. So something that could potentially last, throughout the entire transport, if need be, in that sense of, if we were to kind of lose ROSC and have to go back into the code setting.
Yeah, and what occurs to me in that regard, and it's been a while since I've worked in the field, I'm just going to be very candid, but do any of the devices currently have the ability to plug into the wall so that you could use an inverter?
Some of them do, to my knowledge, yes.
Okay.
And that helps, and you can actually kind of utilize it in that sense. But having that more cables to look at and to not get tangled up, because I don't know about in the different areas that you all are from, but it never fails for monitor cables to quickly become spaghetti to manage those.
Okay. And Dr. Wampler, from your perspective, particularly, looking at things through a research lens, what would you like to see as potential enhancements or wish list items for these technologies?
I don't have to wish. I've been pounding the pavement on. There's really two things that I want to be able to, these devices to be able to do. I want them to be able to somehow augment chest wall integrity, because once my crews, again, CPR for about 10 minutes. Manual CPR is pretty traumatic, and a lot of times we lose chest wall integrity. We need to have something to be able to support that chest wall integrity. The other thing I'd really like to see in these devices is an AED, something where it can shock this patient without having to use a third or an additional device. It's already making strong contact with the chest. Why not just include the ability to defibrillate? Because I think if we can time the shock with max, with minimal chest circumference, during the compression phase, I think we may be able to see some signal there.
No, very good points. Dr. Holley was having some connectivity issues. I was going to try to get his comments, but well, there he is. There he is back. Joe, are you able to hear us okay?
Yes, thank you, internet service provider, for deciding not to grant me internet access for a few minutes there.
So what we were just talking about, Joe, and I think you can just kind of jump right into this, is we're kind of going around thinking, what would we like these devices to do, perhaps that they don't currently do? So a wish list, if you will, for features or functionalities that you would either like to see added or perhaps configured a little bit differently.
I certainly think better integration with our other technologies, including interpositioning of ventilations during the compressions, how to do that and do that automatically for us. And then data collection that can flow into the other myriad elements of data that we collect around cardiac arrest, so that is automatically uploaded and we can sort of sort out mechanical compressions versus other or none.
Okay. Very good. Well, I'm hoping that everyone attending the panel today has come away with some pearls to help inform your decisions regarding the purchase of these technologies, and as has come up in other panels, very importantly, are tips, tricks, whatever you want to call them, to help implement it properly. So that will go ahead and conclude our panel. From this panel, you'll go into our live Q&A session with many of our faculty and panelists participating in that as well. So go ahead and start thinking about your questions and comments, and we'll go ahead and see you over there. Thanks everyone for being on the panel, by the way, too. Thank you.